ECG. Okay?
Okay. Well, for the axis, I think it's normal because it's positive in lead 1 and positive in AVF.
In AVF, it's equidiphasic. It's equal positive and negative. If it's like that, at which specific angle is the axis?
Let me see.
Zero, right? Be zero.
Yes, indeed. 0. Okay. Go on, Mariam. It's 0. Indeed.
Okay. Let's see about I see P waves and
I'm listening.
I'm sorry, I'm a bit sleepy.
No problem. Try to wake up. It's 10 o'clock.
Is sinus rhythm?
Okay, go on. How was the heart
Okay.
rate? You didn't calculate it, or you didn't told me.
Let me see.
Mm-hmm.
So is it around 150?
Exactly. Yes. You're okay. 150.
So it's tachycardia, sinus tachycardia.
When sure that is sinus, you know. When you have 150, you have to decide which kind of rhythm it is, and you have some variants. One is sinus, the other one is atrial fibrillation. The third one is atrial flutter. The fourth one is paroxysmal supraventricular tachycardia, and the fifth one is ventricular tachycardia. All of them can reach this value 150. Just you have to try to find elements for diagnosis one or other from those variants. Try. Tell me about regularity, about wideness, or if the Keres complex is wide or narrow. If there is P wave, if there is any relationship between P wave and Keres complex, this has to be your problems for deciding which kind of rhythm you have.
Well, the QRS axis doesn't seem to be wide. It seems to be.
Axis is not wide. It's only duration. It's not. Axis is not wide. It's a specific angle, but when it is about duration, you can tell narrow or wide. Complex.
Are the P wave morphologies different
Different from what?
from each other? Like, is there different types of P waves in it?
Where do you see? Show me. Just where you see this kind of thing. Come on. Hmm?
The lead where your mouse is right now.
Oh, this one. I don't see that well. The activity here. Okay. Yes.
Isn't it a flutter? Like the way it looks?
Yes, can be because you can see some uh, sawtooth, no? Here.
Yeah.
Yes, indeed. Actually, it's flatter. But it was better to tell me like that it's regular, narrow complex, and the P wave is a little bit funny because this one is too close to the QS complex, this one is too far away, too remote. Yes, but actually, if you bear in mind that here are two waves, like sawtooth, and the complex is coming on one of them, you don't see very well. The second one, you can imagine that it's a flutter. Yes, it's flutter. And you see these waves, HL waves, F, capital F, we call it by convention, in inferior leads. That means lead 2, 3, and AVF, and AVR as well. If we're talking about flutter, all the time, flutter is not seeing like sawtooth in V1, like we see sometimes atrial fibrillation, but rather it is seen by separate waves like here, uh, which have isoelectric line between them. You see, it's not
Mm-hmm.
sawtooth is a wave without isoelectric line. It's continuously up and down, up and down. These are with isoelectric line between two consecutive waves, like here. Here is a longer interval, and I can tell you, can show you. Okay? If
Okay.
you took a look, you would see P waves in V1. Maybe it's a problem for diagnosis sinus street, but these P's are not uh, connected with QRS complex because the distance is different. Okay, good. It's a natural flutter. Very good. I will go to the next one. Oh, sorry, it takes a little bit of time to change the slide. Wait a minute. Okay, you see the slide? The second one?
Yes, we do.
Good. Okay. Um, I will ask Maximilian this time about this ECG. It's a bit bizarre, but still can be read.
Yes. So first of all, I would say it's an irregular rhythm,
Yes, it's important. Clue this one.
and also I don't think it's sinus. At least I don't really see the P waves that well.
Okay.
The axis. Let's see. I mean, it's almost equibiphasic in lead 2, I guess. Also in lead 1, I don't know if it's positive or negative. In lead AVF, it's positive.
Actually, when you counted how is in a specific lead, you have to count the area, positive area and negative area. And if we take a look in lead one, we see
Yeah.
the negative area is bigger than the positive one.
Yeah, so it's negative. So I think it's
Exactly.
maybe right axis deviation.
Exactly. You're right. You're right. Good. Go on.
I would say the QRS complex is wide.
Of course. Tell me, okay, about the heart rate. You have to give some average heart rate because it's different from beat to beat. It's irregular.
Average, maybe also 150 if it's.
It's less than that because if you take a look, the
Yeah, some are bigger.
maximum rate, but most of them are less than that. Okay, let's tell 130 probably would be close. Okay, that means it's tachycardic, yes?
Yes.
Good. Go on.
Well, we can see the V1. It has this M shape, and this might be the bundle branch block then.
Which kind of blunder blood block?
Right.
Right, exactly. Yes, you're right. You're right. Right.
Yes. And also, which looks interesting, is in V2, the ST segment is like notched in a interesting way.
V2, ST,
V2.
segment is, V2, V2
Yeah.
is notched.
I think this is ST depression, but it looks interesting.
Yes, but it's like that.
Yeah.
Tell you a few things. One, usually the right bundle branch block is by prolongation of the final part of the QRS complex. That is actually the R prime here. And these in left leads, precordial leads, it shows like a slur large S wave, which is very, very important for diagnosis as well. It's like as important as the M shape. And these we can see as well in lateral, high lateral leads like the lead 1 and AVL. And you see very nice, a very slur large S wave, you see? These are equivalents of the R prime in V1, and all of them are evidences of right blunt match block, indeed. And the ST changes that we can see are secondary to the block itself. You don't have to be worried about them because they are secondary. Okay, and which treat do we have? We didn't finish with this. Otherwise, it's okay with everything.
Which what? I didn't hear.
Which kind of rhythm? How you call this rhythm?
I'm bad at rhythms. I don't know.
You can judge like that. When you have an RBBB morphology, there are two important variants. One to be ventricular tachycardia, which is originated from the left ventricle. The second one is to be a supraventricular tachycardia, tachyarrhythmia, which is conducted with RBBB. And what is this? If you compare, you put on the table these variants, what do you choose in this trace?
Maybe the supraventricular. It
Can be. But which type of supraventricular one? Supraventricular means sinus rhythm, paroxysmal supraventricular tachycardia, atrial fibrillation, atrial flutter. These are the four supraventricular tachyarrhythmias which can be associated with RBBB and give something alike. But still, there is a clue which point to exactly which one from these is in this case.
Is it for ischemia?
Why? Why you thought about ischemia?
For the P wave?
Sorry.
The first. So it's like
Yes, it is, but I told you before. I don't hear. I told you before, it's a secondary change because of the RBBB itself. Even though there is ST depression, I agree.
Is the AVR positive, more positive, and this is also a sign for ventricular tachycardia? Can it be?
No,
Is it the proximal supraventricular tachycardia?
paroxysmal,
Proximal.
because paroxystic is not close. No, it's not. Actually,
Atrial fibrillation.
oh, what? I didn't hear
Atrial fibrillation.
who you are.
Alexandra.
Alexandra. Yes. Alexandra Wana. Yes. Yes, it's atrial fibrillation actually, because the most important clue, and Alexandra understood, is that it's irregular.
Yes.
None of them, the other variants, is irregular. This is the only one which is irregular, and the RBBB makes the complex wider, but still it's atrial fibrillation. Very good. Good. I will go to the next one. Oh, sorry. Okay. Okay, interesting one. Yes, it's a little bit more complicated, this one. But still, maybe somebody will tell me, and I will ask Ovidiu Constantin Ona.
Yep.
What's your name? You prefer Ovidiu or Constantin?
Video, please.
Ovidiu, of course. Ovidiu, please.
Okay, so looks
I
like
can
heart
help
rate.
you. I will help you a little bit if it's help. You have the same patient in uh, other period. It's the same patient like Maximen has. So yes, try to tell me about it.
Is this after medication or I don't understand?
Yes, after medication. Medication was given for decreasing the heart rate because the patient has heart failure, and she didn't tolerate very high heart rate. And with medication was like this, but it's a little bit different. And please try to describe.
Okay, well, heart rate is around 100, I guess, or maybe less.
Yes, it's less.
Okay, rhythms irregular.
Yeah, it's irregular.
Access seems to be normal.
Yes. More or less.
We do have a P wave, so it's sinus rhythm.
Where do you see the P wave?
Lead 2.
In which bit? Here?
Let's see. First, third, fourth, sixth, and seventh.
Okay. Okay. Go on.
PR interval changes. It's not the same in every. I'm not sure, but would that indicate an AV block?
Which one? Which?
The PR intervals?
No, I will tell you. It's a little bit more complicated, but it's interesting. If you take a look of these, the first three from the precordial leads are more or less alike with what Maximilian told me. They are not very different. The difference is like that. It's not a very complete M, but it's, let's say, a smaller M. You have one limb here, the second one is here, with ST, with S wave, which is enlarged. It is a right bundle branch block, like in the other case. But from the fourth beat, it's completely different. And for this reason, I told more or less the QS axis because you have an axis here in the first 4 beats and a different axis here in the last 4 beats in the standard leads. And the same here, but you don't calculate the axis on precordial. The 3 beats are different, the next 4 are different. Because actually this patient combined RBBB, like here and here, you see the S wave and S wave here with LBBB, which is this one. LBBB,
Yeah, I know.
borderline LBBB is negative. I told you, you can tell about if it's right or left block after the V1. And you can see in this case very nice, because this, when it's positive, is RBBB, when it's negative, is LBBB. And actually, in this case, the patient has LBBB all the time, except when the frequency was very high, when functional block appeared right bundle branch block. It's not easy, but actually it's a atrial flutter. It's not the sinus rate. We don't see that nice, but look here, there are 2 consecutive atrial waves, which are not P waves. And sometimes an atrial wave is before a complex, and maybe you have the tendency to tell that it's a P wave, but it's not actually. Okay, it's not easy, it's complicated, but just I wanted to show you how is rate dependent bundle branch block, and how you can decide if it's left or right bundle branch block after you take a look to single one lead is V1. Okay, it was not easy. And
I have a question.
yes, please.
Wait, so how do you determine that atrial wave is not a P wave?
Because I told you it's not coming exactly before the every complex, and if you can see when it's a longer interval, you can see successive atrial waves, which are these, which are too rapid. It's almost.
But how would you know? I mean, I know that it couldn't be this because of the right bundle branch block, because I don't think you can have both at the same time. But could you not say that it could be like a third degree AV block with that kind of pattern?
When you have a 3rd degree AV block, you have a bradycardic rhythm. One. The second one, it's a regular rhythm. Maybe when you have 2 different rhythms, it happens sometimes in an AV block, in 3rd degree AV block, you can have 2 different morphologies, but usually it's a morphology, it's a regular rhythm, and it's bradycardic. You don't have bradycardia here. And at the atrial level, you can have sinus or atrial flutter or fibrillation. It's not necessary to have sinus rhythm when you have an AV block. But
okay, yeah.
You see how high is the rate, atrial rate. This almost 300 per minute, and you can see here as well, because it's a little bit more than a big block between them. And this cannot be atrial, cannot be sinus. It's atrial flutter. But it just ask me, because it's better to discuss like that. Good.
Can I say something? So this patient changes from left bundle branch block to right bundle branch block like
Because
randomly, or
because the heart rate, when the heart rate is high, has a problem with the conduction on the right branch, and it's a kind of functional right bundle branch block. It happens sometimes. Usually when the patient in sinus rate, and if has a problem of conduction in high rate, will do some right bundle branch block or left bundle branch block. It happens sometimes. It is called rate dependent bundle branch block. In this case, it's a little bit funnier because it's a left here and right here. Actually, it's not complete left because it's not 3. It's almost 3. It's minor left, and this is clear right bundle branch block. Okay, I will go.
I have a question.
Yes, yes.
What treatment was applied here?
Tell me, what do you give to some kind of patient when you want to decrease the heart rate? I'll ask you.
Beta blockers. I don't know. Since you said AFib, maybe digoxin. I'm not sure.
Exactly. Yes, we try to block the AV node because every atrial beat will go to the ventricle through by the AV node. Only in WPW there is some bypass to the AV node. Otherwise, everything is going through the AV node. And we can block AV node with few things. One, with beta blockers. The second one, with some kind of calcium blockers. These non-dihydropyridine. That means diltiazem, verapamil. Or with digoxin. Digoxin is not that good because the effect of blockage, AV node blockage, is through vagal stimulation. And if a patient seems to be very well controlled, like heart rate during rest, usually in exercise, the sympathetic stimulation will be more, and the patient will become tachycardic, even though seems to be controlled, but it's not really. You can give sometimes some specific antiarrhythmic drugs like amiodarone, which are blocking this AV node. Okay?
Okay, thank you very much.
And these kind of drugs this patient actually receive, if I recall correctly, beta blocker and calcium blocker, because flutter sometimes is difficult to control. And the patient ameliorate, improve very much the state of the patient, because actually this patient, I can tell you even more because I know that patient was not far away. This patient actually is LBBB, but more left ventricular hypertrophic pattern here. You see these ST changes, and this patient, because has a aortic stenosis, and because of the hypertrophy, the ventricle is non-compliant, is thick, and receive with difficulty blood from the atrium. And in this patient, if there is a high rate, this patient tolerates very, very bad, because needs more time to fill the ventricle. Okay. I will show the next one. Okay. Who is in charge for the next one? Nicholas.
Hello, doctor.
Hello.
So, let's just take a quick look at this. It's sinus rhythm.
Yeah.
I can't really. I don't see any boxes, so I can't really count the heart rate.
Yes, you cannot. You cannot.
It looks kind of tachycardic to me, honestly, without looking at the boxes. They look kind of close to each other.
No, actually, it's not tachycardia. I mean, it's about 80 because I know, but it's not more than 100, which means tachycardia. From above 100 is tachycardia. If it's 90 something, it's still in the normal range, even though if a patient is bradycardic by nature, when he will be 90%, 90 per minute will be very anxious. Yeah, okay, but it's in the normal range.
Okay. And this line I'm seeing go through everything, is that a part of it, or is that from a chart or something? Is this the QRS?
Actually, this line, probably some of you know it. I was from other opinion. Who knows what is this line which is bothering Nicholas?
Artifact.
No, it's a human artifact. Let's say like that.
So they drew it on there.
Is it to see, like, before does it have a P wave, or I don't know, like to separate, to count?
The line measurement after 25 seconds.
No, 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 no. You don't know, but you are here for learning. Good. This is, we call it spike, and is a line, actually an electrical impulse given by a pacemaker.
Okay.
Okay.
Yes.
It's very short. For this one, it's like a line. It's not like a wave. It's just a line. We call it spike for this reason. Yeah. And there is a spike, which, if you take a look, it's at the beginning of the QRS complex in every beat. Because from this spike starts the contraction, the depolarization of the left ventricle. Okay? Good. And actually, this, tell me about V1 is negative or positive?
V1, you said?
Yes.
Or lead one?
V1.
It's negative?
V1. The complex is positive. How is negative?
Oh, it's positive. I meant it's positive.
Okay. It's difficult for you. Yes, tell me.
Are these what I'm seeing in here? The ST elevations, are these for like the tombstones for myocardial infractions?
These?
Yes.
No, it's completely different. I'll show you. Maybe a tombstone. I'll look for. No, it's tombstone. It's higher. It's like that. It's like rectangular. It's like that. It's higher. No, it's not like that. Okay, I will tell you. It's not easy, but you don't know too much about pacemakers, and I will tell you right now. I told you a few words 2 days ago, but I will tell you again. Pacemakers has some specific way of working. One, the cardio stimulation usually it's in the apex of the left ventricle. Sometimes, and most of the times, you put an electrode in right atrium as well. That will allow you to give a sequential contraction of the heart. And because of the electrode, which is in the apex of the left ventricle, usually the complex is like an LBBB, like a left bundle branch block. That means will be negative in V1 and wider than in this case. And the pacemaker is not working without knowing the normal activity, because it's working on demand basis. That means when it's a native beat, he will not give impulse because it's not necessary, and to avoid a stimulation on the dangerous phase of the QRS complex or T wave, which can cause ventricular fibrillation. For this reason, it is called demand, the pacemaker has to have a sensor to sense the native beats. And this sensor is in the ventricle or in the atrium or in both. And for this reason, there are few letters which define the way of working a pacemaker. The first one, which can be A for atrium, V for ventricle, or D for dual, is the place, the site in which the electrode give the stimulation. The second one, second letter, can be as well, can be A, V, or D, shows in which chamber is the sensor which sense the native activity. And the third letter can be I or T or D, means inhibition, triggering, or dual action, and shows what the pacemaker will do if it senses a native beat. Okay, good. And in this trace, you can tell for sure that the pacemaker has an electrode in the right ventricle, because you see the spike will depolarize the ventricle. That means it has to be in the ventricle. On the other hand, the P wave is normal, but can be a sensor in the right atrium, and to start the ventricular contraction or depolarization at a specific interval after the senses a P wave. It is called VAT, ventricular atrial triggering. That means if the sensor sense a P wave, gives at a specific duration of time a spike for depolarization of ventricle. And this is good because the sequence of contraction, atrial ventricular contraction, remain normal, and the ventricle improve, the cardiac output improve. In this specific case, it's a little bit more cumbersome. I'm sorry, it's not. I don't pretend to have a correct answer from you, but it's an opportunity to explain you something. In this actually trace, this spike is not actually a spike. It's composed from two spikes. One is negative, one is positive. You can see the line is not continuous. There is a mild deviation, because there is another electrode in the left ventricle, and um, these made a synchronous contraction between the left and right ventricle, and it is called cardiac resynchronization. It's not only cardiac stimulation, but it's a cardiac resynchronization, and is indicated, recommended in heart failure with left band branch block. Sorry, it was maybe too much for you, but still, maybe you learned something right now.
It's okay. Thank you.
I hope I have one of easy, and I try to find it. Okay. Who is next? Vladimir. Yes, try to tell me about it, to see if I taught you good or not. Yeah, yeah. Yes. Yes. Yes, agree. Yes, you're right. But what is this pacemaker? In which chamber? Take a look. Yes, indeed. It's an atrial pacemaker. This time, you see the spike is before the P wave, not before the KRS complex. Yes, it's very nice. It's a atrial pacemaker, which can be like function AAI. Let's say if there is a atrial beat, the pacemaker will not give a beat, or maybe it's a complex pacemaker, DDD, which acts like AAI in this case. Doesn't matter. Just I wanted to know how it looks like a pacemaker which deporizes the atrium. Okay, very good. Okay, let's go to the next one, is if there is one. And okay, Munid. Munid,
Yes, Bob.
yes?
Give me a minute.
Yes, of course. It's not easy, but still you can tell something.
So basically, the heart rate is normal. There is no P wave, so it's arrhythmia. Cassie leads to T wave.
Leads to
Normal. As well, your eyes, there is no ice.
no what?
There is no ice in QRS, like no depression is.
Tell me two things. The rhythm is three things. It's bradycardic or tachycardic, and calculate the heart rate on here between these two complexes, please.
Okay.
And after that, tell me if the complex is narrow or wide.
So bradycardia.
How much is the?
Wide.
Can you calculate it?
I mean, one.
Can calculate.
It's 42.
Okay, I agree. Good.
And so wide.
It's wide, the complex, or it's narrow?
The complex, yes, it's wide.
It's wide. Why it's wide? To be wide means to have more than 3 small boxes, which is not the case. Actually, it has not more than that. It's narrow, after my opinion.
Wait a second. Actually, I took it on all, like between R and R wave, not just on the QRS. When I said wide,
You say wide, you told about what?
R interval.
Ah, no, we don't call it like that. We call it large or prolonged, but not wide for the interval. We don't use this one. Okay, no problem. But look, I see here some P waves. Before this one, seems to be a normal sinus rhythm, even though it's very bradycardic indeed. Here we can see a P wave as well. Maybe even here, but I'm not, okay, even here, it's negative. It's biphasic with negative distal part. Here we can see it.
Yeah.
Yeah, it's not easy. I can tell you.
Yeah, I had the look on lead too. That's why I say there is no P wave.
No problem. It's a little bit complicated, this ECG. Actually, it's unusual bradycardic. Probably in this case is six sinus syndrome. That means you have sinus bradycardia and sometimes you have sinus arrest like this. You don't have a P wave and
Yes.
and that complex which is here is actually an escape beat. It's from junctional area from AV node. It's not a sinus because there's no P wave. That one the same. Okay, it's rather difficult to trace, but still it's good to see how it looks like sinus six sinus syndrome.
What? Can you say this again? It's sinus syndrome, is what it's
Six,
called.
six sinus syndrome. Six sinus syndrome
Sinus.
means the sinus node has a problem, or the connection between sinus node and the atrium, or one of them has a problem. Of this kind of patient have bradycardic rhythm and sinus arrest, which can result in syncope and sometimes in death. For this reason, this is one of the one important group of patients which have to receive a pacemaker. Okay? Good. We'll go to the next one and the final one. After that, we'll discuss some cases. And I will ask Elias, which Elias
Yeah.
is, yes. Please try to tell me something about this ECG, Elias.
Okay. Let's see.
You're from Iraq?
Yeah.
Which part of Iraq? I just asking.
Baghdad.
Baghdad. It's easy. Okay, because it's capital. Good. Try to tell me about it.
For the heart rate, it's tachycardia. It's around 150, 130.
How you calculate it, Elias? Explain me.
So we divided 300 to big squares.
Okay. And how many squares are between two consecutive complexes?
3.5. It's like,
Okay, divide 300 to 3.5.
oh, no, it's normal. It's
Okay.
85.
For this
around
reason,
85.
it's good first to calculate and after that to answer.
Yeah.
Because you answer 150 immediately without calculating, and it's not good. And
Yeah, I didn't calculate the half.
you told about tachycardia, which is not the case here. Okay, go on.
Yeah, it's normal heart rate. And we don't see any P waves.
Okay, agree.
So it's not sinus.
If it's not P waves, yes, cannot be sinus.
In V6, we see the depression of ST. It could be right bundle branch block
Or not.
or
Then
not.
the rhythm is regular or not? That means the distance between two consecutive QRS complexes is equal or is very variable?
It's equal, kinda.
Not really. it's not very different, but still it's not equal. It's irregular. It's not regular. Okay.
Mm-hmm.
And the complex is wide or narrow.
It's narrow.
It's narrow. Indeed, you're right.
Yeah.
Good. You have everything in hand. Tell me what is the rate, what's the problem with the QS complex, why it's a little bit different, is abnormal, if you know.
Is it left deviation?
Yes, indeed. I agree. A mild left axis deviation.
Yeah, mild. Is it junctional rhythm?
Junctional rhythm has to be regular. This is irregular.
Okay.
It's something else. What's the prototype of irregular rhythm? To prevent irregular rhythm. What do you think can be?
I have no idea.
It's atrial fibrillation. I guess. Atrial fibrillation. Usually you have to know this kind of ECG. It's simple. It's atrial fibrillation. This is the only clear irregular rhythm with narrow complex, can be even with wide complex as well. Okay, I will ask Valeria right now. Valeria, thank you, Elias. Valeria.
Yeah. Yes.
Except atrial fibrillation and what we already discussed is what is wrong on this ECG, please. Why are these ST depression in V6, V5? You know, or not?
I'm not sure.
Okay, who knows?
Can I take a guess?
Yes, of course.
Is it left ventricular hypertrophy?
Of course. Thank you. Who you are?
Ergin. Ece.
Yes, it's Ece. Yes, it's a left ventricular hypertrophy, and this is very typical. ST depression secondary to LV hypertrophy because it's a little bit convex, and the T wave is asymmetrical. This is very typical. Usually, this kind of ST depression has a mirror appearance here in V1, V2 with ST elevation. Actually, you can see with a concave upper part of the elevation. And there is another thing, the hyper voltage. Tell me, Ece, what about the hyper voltage? It is, it or not? How we calculate it?
Isn't it supposed to be greater than 25 or 30 millimeters?
What?
The amplitude. In V1, V2, it's the S, and in V5, V6, the R.
Yes, we use this
The
Sokolov-Lyon index, but the value is not good that you told me. That means S wave V1 or V2 which is very deep, plus R wave V5 or V6, which is huge, has to be more than 35, not 25, 35 millimeters, but only the R wave probably is more than 35. It's very clear and very strong hypervoltage in this case. Sometimes if you have more than 12 millimeters in AVL is valid as well. Good. This is atrial fibrillation with normal range heart rate, with some mild left exit deviation, and with a huge LVH. Probably this excess deviation is because the LVH as well. Very good. Good. I finish with this. We'll start to discuss cases, but let me disconnect this. And I will put the next one. Good. We'll go to the next one. We discuss about cases. I will ask sometimes you about some opinions, but I will present you the case. It's about 58 years old woman, you see, was admitted for fever, which was rather high, nausea, diarrhea, which appeared in the last days. The history of the patient, she has a mitral valve prosthesis implanted in 2005, and actually the patient came a few years ago. And at the physical exam, the fever is mild when it was in the emergency room, blood pressure normal, heart rate normal, normal prosthesis sounds. You know, have you heard valvular prosthesis?
No.
If you'll come in the ward, maybe you'll have some patients, but usually the sound 1 and sound 2 are louder and more metallic, like tonality, like tone. It's like that. And when you hear very well, and sometimes, most of the times, you can hear without stethoscope, if you are near the patient and you try to be very attentive, you can hear the sounds like an electronic watch, if a wristwatch. I don't know if anybody has a wristwatch nowadays, but usually it's all that. You can hear if you stay near the patient, and actually the patient hear very nice these sounds themselves during night when it's silent. Okay, but still with stethoscope, the sounds has to be very, very neat. If you don't hear the sounds like metallic, that means that probably it's a problem. It's some panus or some clot there which prevent the proper sound. Okay, except this, in this patient, oh sorry, I will put the pen, the laser pointer, yes. Except this, the patient have a systolic murmur, not very strong, in the fifth space left parasternal, which increases during inspiration. Nothing in lungs, but systemic stasis, as you see here. What means a systolic murmur in that area which increases during
It means it's a right-sided heart murmur.
Yes. And which kind of right side heart murmur?
I'd say like tricuspid regurgitation.
Yes,
maybe.
because it's systolic.
And then he's got signs of right heart failure.
Indeed. Yes. Yes, it's a tricuspid regurgitation murmur because a systolic murmur in that space and typical increases during inspiration. This is Romano Carvalho's sign. The right-sided murmurs are increasing during inspiration because a bigger the increased preload during inspiration. Okay, good. It's in Romanian, but maybe you can understand. Yes, it's a track of the history. The patient originally has mitral valve disease by rheumatic origin, etiology, and sometimes she had infective endocarditis. This is a contraction from Romanian, sorry. And after that, after curing of endocarditis, the patient have a surgery and she received mitral valve prosthesis, which is called Pop de Popa. This is a surgeon, actually, he worked in our department, in our hospital, and he invented a biologic prosthesis with pork pericardium, like for the leaflets. Okay, but after a while, the patient have a recurrence of infective endocarditis, and after the treatment, the antibiotic treatment, the patient, because the prosthesis was broken, she received a mechanical prosthesis with bileaflet prosthesis. I showed yesterday. Name the prosthesis was sorry bicarbon, and again, after a while, she have recurrence of infective endocarditis on this prosthesis, and after the treatment, the patient received another metallic prosthesis, Edwards Mira, and 29 is dimension, the diameter of the prosthesis. And this time, because of tricuspid regurg, the patient have annuloplasty for the tricuspid valve. The annuloplasty means an artificial smaller ring is implanted to diminish the area of the aortic valve. Okay, investigation for this patient, ECG, chest X-ray, blood test, echocardiography, and this is the ECG. And who will read this ECG? Who is the next one? Is Olivia Akashie. Are you here, Olivia?
Yes, Professor.
Yes, try to read for us this ECG. Regular or irregular, narrow or wide complexes, average heart rate, KRS axis.
I can't clearly see a P wave in lead 2.
Yes, there are no P waves.
Yeah. We have narrow complexes.
Yes.
It's about normal for the axis.
Yes, again.
Heart rate's about normal too.
How much? Normal?
It's about normal, yeah.
Oh, normal. But Take a guess. How much more precise?
A little less than 75.
In that space, probably, but
Yeah.
put everything together, probably something 80 something. Yeah, okay, great. What rate do you have here?
Sorry?
The rhythm. Tell me about the rhythm.
Okay. Probably it's irregular.
Regular or no regular? I didn't understand.
It's irregular.
Irregular. Yes, it's irregular, indeed. And how we can tell which rate do we have? Sinus, flutter, or ventricular tachycardia, or what do you have here? What do you think?
I'm not sure. Maybe an atrial flutter.
Actually, it's atrial fibrillation because you don't see the F waves for flutter all the time. The F wave, the tooth when it's atrial fibrillation, sometimes you see only a flat isoelectric line, even though in this case it's not the case because you can see here in V1 some small waves between the complexes. These are enough for telling about atrial fibrillation, and here as well, but in this case you don't have more than that. It's atrial fibrillation. Okay, there are some negative waves, but are diffuse and are not specific in this case. Well, okay, good. We'll go on to tell you about this case because it's interesting. Okay, good. This is the chest X-ray, and I'll ask now Halime to describe something in this chest X-ray. If
I'm
you're
not
okay.
very good with X-rays, but
Yes, but we discussed something yesterday. Tell me, what do you see there, and we'll discuss. I will help you.
yeah. So we talked about like thoracic index last time.
Okay.
It looks okay. I think it looks. I can see that the lungs are like congested.
The lungs are?
There's like white stuff there, a little bit.
This kind of stuff?
Yeah.
Or, yeah, yes. Usually it's a stasis. It's a pulmonary stasis, yes, indeed.
There's a pacemaker, maybe? I don't know. There's this.
Yes, yes. This is a pacemaker, actually. You can see this pacemaker, it's a closed device. You cannot open to change the battery. This is the battery, this half, which is opaque. Usually, after a few years, usually 5 to 10 years, it is changed completely, entirely. That means take away and throw it and put another one. And there is a line here, which is the electrode, which is going in the right ventricle. We don't see the tip, but you see the rest of the line. Yes?
Yeah.
Okay. It's pacemaker, indeed. But what about the heart opacity? What is not normal there? What do you think? What you learn?
I actually don't know.
You don't know. I will tell you again. I told you 2 days ago. We describe like that 3 arches on the left side. This is the inferior one, this is the middle one, and this is the upper one. And 2 arches on the right side, the inferior one and the superior one. Okay, here we have an enlargement of the heart because the index it's more than 50, but the left inferior arch it's only mild increase. What is very special is the middle arch, which has to be concave like that, and in this case it's bulges. It's because the pulmonary artery which is enlarged. And finally, you have the dilation of the inferior right arch, which is formed by right atrium and right ventricle. Okay, that's the X-ray, and I'll go to the next investigation. Blood test increased C-reactive protein, which is what means increased C-reactive protein? Who knows?
Inflammation is increased, but it's
Exactly.
non-specific.
Non-specific marker of inflammation, indeed. Positive hemoculture with Staphylococcus and an INR of 5. I will ask who? Halime, do you know what is INR? This one. It's a blood test. Do you know something about it? No. Halime? No. Okay.
No, I don't.
Anybody who knows about INR?
It's a
Is in ratio.
Yes.
blood clot coagulation. Prothrombin type.
How has to be this to be good coagulation? This is used for
Between 2 and 3.
anti-vitamin K drugs for decreasing thrombogeneity, and has to be for therapeutic range 2 and 3.
Yes.
Yes, it's maybe, but we can tell even better.
Is it below 1?
What?
Below 1 is a normal range?
Yes, 1 is normal range, but during treatment has to be increased to be between 2 and 3.5. And usually there's some mild differences. If it's for atrial fibrillation, we are satisfied between 2 and 3. If it's prosthesis, especially mitral prosthesis, we prefer to be from 2.5 to 3.5 because it's more thrombogenic. But this 5 is, for instance, too much, and this means that the patient has a risk of what?
Stroke?
In a way, but of hemorrhage.
Bleeding?
Bleeding, exactly. If it's less than 2, it's the risk of thrombus. If it's more than 3.5, it's a risk of hemorrhage because the blood will not clot it, even in a normal condition, normal situation. Okay, good. But the main thing that the patient has positive hemoculture. That means if we put blood on the culture medium, will develop bacteria, and the bacteria in this case is Staphylococcus. Probably it's white here. Okay. In the echo examination, the prosthesis seems to function normally and no vegetation were seen. But then, because there is a strong suspicion of vegetation, of endocarditis in this case, an transesophageal echography was done and actually small vegetation was seen. And for you have a lecture about endocarditis, no?
Yesterday we had.
Yes, okay. And there are some criteria which are accepted right now for diagnosis endocarditis. And these criteria, the most used criteria in practice is Duke criteria. And you can see them, all of them. And what we have in this patient, I will ask who is Eche. Eche, tell me what it's possible, or it's we can count it from this patient if you were attentive at the beginning. Yeah.
So we had the positive blood cultures.
Yes. Good.
There were vegetations. So
Vegetation. What else can be like endocardial involvement? Abscesses or extraction of valve or leaking prosthesis. That means it's how to say, it's not well stitched. Yes, and the blood is coming near the prosthesis. Okay, this can be, but we have vegetation. You tell me. What about predisposing heart condition, usually valvular one?
Since the patient has a
Yes, has prosthesis. Yeah.
I don't remember mentioning fever.
Fever. It was. Yeah.
Oh, okay. Sorry.
At the beginning, that was the reason for admission.
Okay. Increased INR could mean hemorrhage, maybe?
No. It's only predisposing, but it's not actually hemorrhage. Yeah, she doesn't have vascular phenomenon. Immunologic, like different kind of pathology, which was it's induced by immunologic reaction, like glomerulonephritis, but it's not the only one. No, in this case. And some
inflammatory response.
You have.
I think so.
Exactly. How many major? How many minor do we have in this case?
So 2 major.
Yeah.
1, 2, 3 minor.
Yes. If we take a look downstairs to the diagnosis criteria, do you think it's endocarditis or not?
Yes, definitely.
Yes, definitely, exactly. It's very clear, very sure. Even there is something else, the patient has previous episodes of endocarditis, that it's even more probably in this case. But after a day, the patient has paresis with right limbs, upper and lower limb motor deficit, and we have a high suspicion of CVA, and a cranial CT was done and shows some abnormality here. Okay, who can tell me in this case what can happen? Why the patient have a CVA, cerebrovascular accident? Eche, if you want, otherwise everyone which want to tell me about this. Reason for stroke or hemorrhage and rationale for this.
Maybe embolized?
Sorry, Prasha, continue.
Who starts?
Maybe embolized?
Embolization from
maybe from valve to that?
From the valve, what? I didn't understand. Tell me again. From the valve, what? Okay. Somebody else.
The
vegetations.
Okay, can be embolization or vegetation.
atrial fibrillation.
Atrial fibrillation, the second. Yes. or from the prosthesis itself. Sometimes some thrombi are formed on the prosthesis, even though in this case it's improbably because the INR was high. But you know how it is with antivitamin K. You cannot maintain the same good range all the time. There are some periods in which the range is too low or too high, and in those periods, some thrombus can form, and after that to go away, maybe in the head. Okay, but what about the hemorrhage? There is possibility to be hemorrhage or not?
I think yes, because the INR is like 5.
Yes,
So
yes. If the INR is high, can be hemorrhage everywhere. It's not extremely high, but it's still high. Okay, but sometimes a complication of endocarditis is um, mycotic aneurysm. That means it's an infective aneurysm, infective embolus in the wall of the artery, and form a dilation, an ectasis, which is called mycotic aneurysm, and sometimes not infrequent, is formed in the cerebral circulation. Maybe this kind of mycotic aneurysm was ruptured, and this can be a cause of hemorrhage. And we didn't tell till the end, when it's an embolus from the vegetation, it's an infectious embolus, can make an abscess or an infection in the place in which this embolus reached. Okay, but this actually is cerebral hemorrhage. We consider that's much more probable to have a embolus, but was not the case. Instead, the patient has hemorrhage. This is subarachnoid, but this is intracerebral, two sides of hemorrhage. With treatment, the patient went well, but there are some problems that we have to cope, and we discussed about this. Think about it. We have brain hemorrhage, and on the other hand, metallic microprosthesis. That means something which is prone to do a thrombus. What do you suggest to do in this case? How to treat this patient? Give me an opinion.
Fibrinolysis.
Fibrinolysis, oh, will be a catastrophe. Fibrinolysis, when you have a cerebral hemorrhage, it's not allowed to give fibrinolysis because will kill the patient.
Maybe anticoagulant?
Anticoagulant. You consider it's good to anticoagulate because the metallic prosthesis. Yes, but you know, in practice you have to make a compromise. It's not easy all the time. This patient is in a very bad situation. On one hand, she is at the risk of death because of brain hemorrhage. On the other hand, the risk of death because of the blockage of the mitral valve prosthesis with a clot. But in the specific moment in which the patient was, the most dangerous disease was the brain hemorrhage. And for that reason, even though the patient has atrial fibrillation and mitral prosthesis, the anticoagulation was stopped for a while, for a few days, till the brain hemorrhage have a tendency, a trend of disappearance. And after that, after a few days, less than 1 week, we started again with caution the antithrombotic treatment, and that was how it was treated, and fortunately this patient went well. After this one, what to do to this patient? We do surgery or we give only medical treatment after the antibiotic treatment, which usually is 6 weeks for staphylococcus endocarditis. What's your opinion?
I would say just do conservative treatment now.
Why, Joachim?
Because of a risk for like disseminated intravascular coagulation or something like that happening for a major surgical procedure.
Okay, but if you think like that, you don't operate on anyone because there is a risk. Now, for this specific patient, we can afford to have only conservative. Indeed, you're right, because actually the valve, the prosthesis, was not destroyed by the infection. Actually, the surgery after endocarditis is not mandatory. It's only to repair what happened, what is destroyed by the endocarditis. In this case, nothing was destroyed. Was a vegetation which disappeared after that, and nothing else. On the other hand, if you recall at the beginning, this patient has already 3 interventions. Every intervention is riskier from than the other, that previous one, and she had 3 different prostheses. And if you do an intervention after endocarditis, we have um, high risk to have another endocarditis on the prosthesis. Then, for this case, probably it's better to give a longer treatment, antibiotic treatment, to cure the infection, and after that, only to give medical treatment. And that was given actually in this case. Okay, do you see the next one?
Yes.
Yes, who is the next? Is Esra. Okay, I'll ask you soon. Okay, we're talking about an older man. You see, most of my patients were younger, but this is older, with diabetes mellitus, and treat with insulin. That means usually a more serious kind of diabetes mellitus, with high blood pressure, high cholesterol, and former smoker. He was admitted for dyspnea +3. I explained yesterday how it's +3, which were aggravated in the last month, and has a history of 2 myocardial infarction and CVA, which was completely recovered, and is treated for prostatic cancer and has anemia because of gastrointestinal bleeding. In the physical exam, is a pale person with normal blood pressure and heart rate. We don't feel any apical impulse, but at the physical exam can be heard a third heart sound and a systolic murmur in mitral area. What do you think, Esra, that in this case, which presented with this, with those elements, what means the third heart sound in this patient?
I think it's a ventricular gallop, maybe.
Is gallop. All the time is gallop. This is the name of it. But what is the significance?
Maybe it's a mitral insufficiency.
That is not a very important murmur. It's 2 from 6. It's something else which is more probably to be the significance of the third heart sound in this, the protodiastolic gallop in this patient. But you're right that in mitral regurgitation can be a third heart sound. I agree.
Mm-hmm.
The case here.
I'm not sure.
Okay, means LV dysfunction. Okay, I will go to the next slide. Can you tell me something about ECG, or is difficult for you?
I'll try.
Okay, good. I'm glad that.
I can see that there is an axis deviation, and actually I can see a P wave. And it's a normal rhythm.
Normal, like heart rate or what?
Yeah, heart rate.
Yeah. How much is the heart rate?
Okay.
Exactly. It's not complicated in this case.
It's around 85. 80.
I think it's less than that. Okay, let's say 80. Okay, good.
And the QRS is a little bit wide.
Yes, you're right. What else, please, Isra? Okay, do you hear me?
Yeah.
Do you have something more to tell us or not? I will tell if you don't have.
No, I'm not sure.
Okay, I will tell you. It's a little bit difficult because it's a sinus read. Only the P wave is very far away because it's the first degree AV block.
Yeah.
This is the P wave. This is the P wave. Second, there is a conduction problem, interventricular conduction problem, probably right bundle branch block, which on which is added anterior myocardial infarction. For this reason, we don't see any R wave. We see only R prime here. R wave is replaced by the Q wave. Make sure the patient has a Q wave in anterior lead and an inferior lead because has myocardial anterior and inferior myocardial infarction. And still the patient have ST elevation V3, V4, V5, and 6 is a frozen aspect of the ECG. This usually, I told you, but I remind you, is suggestive of LV aneurysm. And we go further. Okay, sorry. I have all the time to change something here. To show you And this is the chest X-ray. Who can? Who? Majid.
Yes, doctor.
What you can tell about chest X-ray? I know
The
that.
inferior. Yes, go.
I know that you didn't have radiology yet, but still we discuss a little bit. Maybe you can tell me something.
The inferior left arch.
Yeah.
It's enlarged.
Very good. Very good.
And the middle one, the middle.
Twice.
What?
Twice. I try to respond.
Why is?
Actually, most important thing here, the left inferior arch is enlarged, indeed. But there is something. If you take a look to this inferior arch, you can see something, a line here. You can see or not?
Is this pulmonary congestion? No.
What? What is this?
Congestions?
No. I mean, not in the lungs. Yes, it's congestion. Indeed, you're right. But there is a very fine line which is around the LV apex, and actually, an lateral view shows something here. This is lateral view, and this is a calcified left ventricular aneurysm. All the time, we can see better in the lateral view than in the posterior anterior view. You can see, if you are attentive, as a fine, very intense white line here, but here you see even better. And for seeing perfectly, we can use the image intensifier. This is in the cath lab, and this is the result. There is a calcification of the left ventricular aneurysm. You see here this black line this time, which surrounded the apex of the ventricle. This is the echo. You know, you have thought about echo, know something or not? This is the usual projection. Is the most common projection, most known projection in echo. And this projection, here's the left atrium, this is the mitral valve, this is the right ventricle, the left ventricle, sorry. This is the right ventricle, and this is the aorta, ejection tract and the aorta. We don't see the right atrium in this image. And actually, in other projection, we can see the left atrium, right ventricle, and left ventricle. And the apex of the ventricle, this with a star, it's actually the aneurysm. The aneurysm will be like that. You see a drawing, and we discuss a little bit about aneurysm. We'll do like that in diastole will be normal, but during systole, some blood, instead of going to be ejected in the aorta, will bulge in the aneurysm, which will be dilated. That function, the aneurysm. And for sure, we already talk about this. Can have heart failure or arrhythmias or embolus or rupture for this aneurysm. In this case, what to do with this patient? What do you think, Majid? we operate this patient or not? What's your opinion? Do you hear me?
Yes, I hear, Doctor.
It's not easy, but just we try to do a clinical judgment.
Yes, he has a high risk in surgical cases, so we can't perform surgical procedures on him.
Usually, we in important aneurysm surgery is indicated, but in this case, because the aneurysm is more than 50% from the LV volume, and the aneurysm is calcified, and the ejection fraction is diminished, will be a high surgical risk. And in this case, we just treated the patient medically. Okay. I will tell another one, and will be the finish one or the final one, or you prefer to finish here? How do you want?
Let's do one more. Let's do one more.
Okay, I try to be quicker. Woman, 48 years old, high cholesterol, smoker, alcohol abuse. It's not that frequent in women, but still. Admitted for dyspnea, severe dyspnea, fever up to 39, coughing in the last week. And in the physical exam, normal blood pressure and heart rate with a systolic murmur in the fifth space, the costal parasternally, with jugular vein distension, with hepatomegaly, with edema, lower limb edema, and pulmonary rails. This is ECG, and I will ask Lorin Suleiman to tell me about ECG. It's not difficult. Read the ECG, please.
Okay, I can see the P wave,
Mm-hmm.
and some of the P wave is conducted and some of them now.
Some of them are not conducted, you told me?
Just
I think everyone is conducted.
yeah, I'm sorry.
No problem. What the heart rate? How much is the heart rate?
It's normal heart rate.
Yes, but specific.
It's
How much?
approximately 75 or 70.
Okay, 75. Great.
Yeah.
Aqueous axis. Actually, in this case, it's not easy to calculate because in almost every lead, it's small or equidiphasic. That means we don't calculate this. Actually, that's all. It's only a sinus read without anything special. Okay, thank you. I'll go to the next one. And on this chest X-ray, we can see. I will show you. Don't ask from you. We can see that it's a lower inferior arch, left arch enlargement, but the lungs are very, let's say, there's stasis in the lungs, and here it's a round opacity, which without anything inside, and actually it was a pulmonary abscess, which was evacuated. And if we go further, we can see the echo. In echo, echo shows right chambers dilation. That means left and right ventricle, good function, and the tricuspid valve vegetation with severe tricuspid regurgitation. In echo, we use 2 or 3 techniques. One is by the two-dimension echo, in which you can see anatomy, and this is the vegetation. This is the right ventricle, and this is Doppler, which shows some diagram about the sense and the velocity of the blood which are going through the valves. And this is a more clear echocardiography, and you see that the right atrium and the right ventricle are dilated. We can tell that it's right and left after the position, but usually the left ventricle is rounder. It's like that. It's ovoid. It's not ellipsoid. It's not round. And you see that the septum bulges towards the right ventricle because the pressure is much less in the right ventricle than in the left ventricle. All the time it's like that, except that diseases in which the right ventricle pressure becomes bigger, higher than in the left ventricle. This is rare, but this is the normal appearance with, let's say, an ovoid left ventricle, and this is the right ventricle, but are dilated. Okay. And the blood tests show positive hemoculture with staphylococcus and with leukocytosis. And what about the due criteria? Do you have any due criteria? There is an endocarditis or not? Can you tell me who is next? Lauren, can we? I'll go backwards to see the due criteria and to decide which one is positive or not. Do you have endocarditis or not? Tell me which is present, which is not present here. Lorraine, Suleiman?
Yes. The positive blood culture is present.
Yes.
Okay, so one major.
Yeah.
And
vegetation, it's the second major evidence of endocardial involvement, means vegetation is present as well.
yeah.
Okay. Go to the minors.
Yes.
Heart condition. The patient has no heart condition before. It's not present. Fever or not? Do you remember the patient had fever?
No, no.
Yes, she had fever.
Yeah.
This was the reason for coming, and the patient has inflammatory response. That means two major, two minor. It's endocarditis or not?
I can't hear it. Can you repeat, please?
We have two major criteria and two minor criteria. Do you think it's endocarditis or is not endocarditis? Take a look downstairs at the slide. It's written. Okay, it's endocarditis. We have two major. You don't have to have any minor to diagnose the case. Okay, I'll go to the case that we discussed. Okay. The patient received antibiotic treatment 6 weeks. and this was the result. The heart is better, and the lungs for sure better. Still, we can see. I don't know what's my pointer. We can see. Okay, a little bit enlargement of the lower arch, lower right arch, because of the dilation of the right chambers. And the patient has only medical treatment. I wanted to show you the tricuspid endocarditis, because it happened usually in patients with low immunity and the patient drug addict patients, which inject drugs with syringe and needles which are not sterile. And the first valve which is involved in this kind of disease is the tricuspid valve. The second one is pulmonary valve. Very rare the left-sided valves. And the most frequent germ is Staphylococcus, because usually it's on the skin. And the complication can be like pulmonary emboli, and pulmonary abscess, because the embolus is septic, like in this case. Okay, that's all. Tell me if you have any question or you want to tell me something. Otherwise, we'll finish.
Excuse me, doctor. I entered later because I didn't have internet connection.
Who are you?
Zabi Kusai.
Sorry. Kusai Zoabi. Okay, good.
Yes.
Yes, sir.
Okay.
Same for me as well.
Who are you?
Balasingam Prashalini.
Yes. Yes. Rosalyn, good. Very good. You are from Colombo, no?
Yes.
Okay, good. Other questions, please. If you have something to ask. Okay, I fix it.